talk first of all around what I term as the industry standard, which is the standard beliefs and methodologies and strategies that are currently used. I'll talk about why these have such poor outcomes, and also why it's accepted, I suppose, and why they're continually applied. And then I'll talk about what I'll term the art of the possible, which will be both my own story and those of others who I've helped. As far as the industry standard's concerned, I've presented at 2 World Congress for Neuro Rehabilitation. Within both of those congresses, there's been a series of seminars or presentations which they've termed the clinical pathways, which are the internationally standardized gold standard for relearning to walk following brain injury. One of the founding tenets of it is what you see here, which this is a graph that shows the statistics around movement recovery with brain injury patients. That graph I was talking about, and you'll see the 0 to 24 hours is post-injury, so that can either be stroke or surgery. Essentially, it's a little bit different if you've got an in situ cavernoma, and it is the existence of the cavernoma itself and the pressure it's exerting that's causing the problem. There will be a number of things within the presentation that will be directly relevant to that. Ultimately, one of the overall lessons is movement, and the underpinnings that dictate quality and success in movement is relevant for all. And so if you've got an in situ cav that's causing the problems, everything which will lead to improved movement quality in other individuals will help your situation. Now, ultimately, the only thing that is going to resolve it is removal of the cavernoma. However, following of the sound movement principles will lead to benefit. So take you back to the graph that you can see here. So we start off immediately after injury, and then you can see in that first 3 months is when the most rapid progress is made. And then you can see once it starts getting into that 3-month area, it tails off, almost flat lines. And it actually stays, the statistics show that recovery stays at that gradual level up until about 2 to 3 years, when it's then said to shut off completely. If you want to move on to the next one for me. So what they advocate is immediately trying to teach the patient to walk. Now, it will sound very intuitive, but I'll lead on. I'll go on to later where the failings in that are. But this is the advocated strategy anyway, is that you immediately try to get them to walk. If they can't self-ambulate in any way, then you do walking with assistance, and you just have repeated attempts at walking is the overall premise for your rehabilitation, to try to teach you to walk again. They actually advocate intensity within these sessions. What that's based on is increased effort and increased heart rate, which correlates with production of something that's called brain-derived neurofactor, and that encourages the building of new patterns in the brain. again, which intuitively or at face value would seem to be a positive. And then outside of that, they don't really have much of a strategy other than what I would refer to as a parts-led model. Whereas if they find a muscle that's tight, they try to stretch that muscle. If they find a muscle that presents as weak, they try to isolate it and give it strengthening exercises to strengthen it. Now, all of those approaches immediately trying to take advantage of or make best use of those 3 to 6 months where you get most progress. That would sound reasonable. But then you also have to ask the question, why are outcomes so poor? And I suppose the answer to that could well be, well, brain injury is a real serious deal, which it obviously is, and this is the best we can do with what we've got. So there's an actual stated belief that, and it's not actually on that slide that you can see there, but it's actually part of the clinical pathways that they say that no significant improvement can be gained once the patient is 6 months or more post-injury, and that the therapist should look for compensation strategies. And the whole of the industry is based around that. The only research I'm aware of, other than my own, which is going on with respect to trying to get improvement in that post 6 months area, is actually with direct electrode stimulation of the brain and or use of exoskeletons. And an exoskeleton is, it sounds, I don't know if any of you have ever seen RoboCop, but that's exactly what they're talking about, is putting the person in some form of mechanically assisted and or controlled suit of armor, let's say, and for that to control the movement. And somehow, hopefully, that the patient will learn the movement from there. Potentially that sounds intuitive, but it's just bad science as far as anyone trying to think that is how movement is learned. So this 6 months window seems to be what is driving everything. Now, if you've sustained brain injury, there are pretty much only 2 routes towards recovery. And that might be what you call neurogenesis, which is if you've got damaged tissue, that tissue regrowth to facilitate recovery. Now, that will happen to an extent. It's incredibly slow, but also all of the different structures within the brain are so eloquent and complex that regrowth is difficult. It's a little bit like if you lose an eye. You can't regrow another eye. It's too specialized, And then you've got what's called neuroplasticity. Now, you can look at the brain as a big computer, which has extremely complex software running in there. And the software programs enable the brain to control the body to perform functions. Now, if it loses some of those software programs, either because the physical space where that's stored and or run is damaged, or if it's, shall we just say, the software's wiped in whatever way. Well, the way the brain tries to cope with that is basically its standard mechanism of learning and intellectual growth or neurological growth, which is neuroplasticity, growing new pathways. Now, ostensibly, that is experienced in people when they learn new skills, let's say playing the piano. It's through neuroplasticity that you will build that new capability. Well, you lose capability through brain injury, similar again, it's still going to be neuroplasticity that facilitates the recovery. Now, neuroplasticity exists for life. It is there through the entirety of anyone's life. So given that fact, and that is how the brain copes with new ways to perform skills which were previously executed by damaged parts of the brain. If neuroplasticity is there for life, well, why have we got this 6-month window? Now, the way neuroplasticity works, it builds hierarchically, like it will build a pattern on a pattern on a pattern. So the way you can look at it maybe is you can look at it as like putting books on a shelf. So first of all, you've got an empty shelf. You can put a book on the shelf. I'm consciously trying not to say book, which is Scouse for book. So if I slip into it, you understand why. So you're putting a book on the shelf, and then that gives you the information within that gives you capability. Then you can build on that, and you can put a second book on the shelf and a third. But the order that the books are put on is important. It can't be changed. So if you let's say you've got a series of 6 books, the Harry Potter series, let's say, if you put the Deathly Hallows on first and then put the Philosopher's Stone next, and then you put the third one and the fourth one, you can't go back and change it. Once neuroplasticity has started building a pattern, it can't go back and change the start. It would have to dispense with the pattern in its entirety and start again in its entirety. Now, that's something which happens all of the time. You can look at it as spring cleaning within the brain. It removes all of the patterns that are dysfunctional. And the way it identifies them as being dysfunctional is that they don't get used. If they don't get used for long enough, the spring cleaning will come in and get rid. Now, once you've got different patterns or different bookshelves, they can be rearranged and used together to produce ever more complex results. But it still comes back to that premise, is once you've started, that order is how it is. So it's really important that the base is correct. And so to go from the bookshelf analogy, you can go into, say, like a pyramid analogy. And it's really important, the size and quality of the base, because you're going to build something on top of that, on top of that, on top of that, until you get your highest movement quality. Because it's the software patterns that controls the movement. And so the neuroplasticity and how that's built, the base is really, really important. So that graph you saw was driven by statistics. So, that's fairly objective. So if I'm here arguing for neuroplasticity and saying that it's there for life, which is a scientific fact, it is there for life. Well, the statistics are showing that this 6 months limit, let's say, I'll refer to it as a glass ceiling from here on in. The statistics say that's there. So why is that? Well, there's 2 parts to movement, and you can look at it as being hardware and software. As we've just been talking, you've got the software in the brain which controls the neurology, but then you've also got the working parts, and the working parts of a machine is it's crucial to its operation, and certainly the range of motion of the working parts. You can think of it as any machine. Let's say a car engine. So the pistons in the engine have got to go through their full range of motion. If they don't, well, that starts to compromise performance, and it can compromise it to different levels depending on the compromise to the range of motion. Because range of motion, basically the position of parts in relation to each other, is extremely important, especially for something that called biomechanical advantage. Physics and mechanics will present at every level with the most simplest things, especially with movement. So think about a door on a hinge. Where do you put the handle? You don't need a science degree for this. Everyone knows where you put the handle on the door. Because if you put the handle next to the hinge, you wouldn't have biomechanical advantage. You wouldn't have the leverage to open the door. Yet, same handle, same door, same person, put that out in the right position, and you can open the door. So range of movement will dictate biomechanical advantage. Now, the laws of physics don't change because you're talking about the human machine. Now, can be different belief systems about how you think we all got here. However, I don't think anyone can dispute the process of evolution. I'll leave the creation aspect open to discussion, but you can't dispute the process of evolution. And the last evolutionary process that took place in the human body was approximately 10,000 years ago. So our culture and lifestyle has changed considerably since then. And so the current Western movement lifestyle is not sufficient to maintain the working parts and range of motion of the human body. So it basically just deteriorates with time. And I think all of us can probably recognize this. I've been extremely active throughout my life. However, especially anytime I've got a job which might entail me sitting down for the majority of the day, your mobility gets significantly affected. Now, if your mobility is affected, then your range of movement's affected, which means your biomechanics are affected. Now, the majority of people who suffer stroke and surgery as a result of cavernoma, I would suggest is probably, Joe, what do you think? What do you reckon? 50 plus? Absolutely, 40 plus is where the mean is going to be. Now, this isn't exclusive, but what would you say, Joe?
I'd say you're probably right around 50, 40, yeah.
Yeah. So in the Western world, what 40 or 50-year-old has got anything like authentic range of motion? And when I say authentic, I mean the range of motion we're designed to have. And certainly nothing like the range of motion we had when we were infants, when we were first learning to walk. Now, this is really important, because when as an infant, you're building this neuroplasticity, building these patterns, you repeat the productive and the efficient movements, and you steer away from or tend not to repeat anything which is not productive or efficient. And so, as I was mentioning earlier, the spring cleaning will take place. Anything which doesn't get used will ultimately go, and then you will build on what does get used. So when you're the adult and you haven't got this range of motion available, and then all of a sudden you're stricken by brain injury, which robs you of the ability to walk, you've got to try to learn to walk again. Now, the day before you had the stroke or the surgery, let's say you were walking then, now it will be walking after a fashion. It won't be the efficient and biomechanically elegant walking you will have been doing, let's say in your teens or early 20s, but you could ambulate. But what is the case is, yes, you could walk, but you most likely don't have the mechanical skills to be able to learn to walk, because you can't experience biomechanical advantage and your movement brain discriminate between what's a good option or a bad option, because the movement you're being taught, it all feels like a bad option. It's all biomechanically disadvantaged. But then also, if you think about it, everyone's Western movement lifestyle is suboptimal up to the point when they have the stroke or surgery. Well, what's their movement lifestyle going to be like thereafter? Let's say for the first 3 to 6 months, it's actually going to deteriorate. So over that period when they're trying to rehab, if all they're concentrating on is attempts at trying to walk, well, they're working with bad mechanics. So first of all, it's going to be very difficult for the patient, but also he's going to be learning bad patterns. He's not going to be learning how to use biomechanical advantage. The bottom layers of the pyramid are all going to be being built with poor range of movement and all of the poor decisions that come as a result of that. And as I said earlier, when you put a book on a bookshelf, you can't take it off again. That order is permanent. The only thing you can do is get rid of that pattern and start again. So this is why this 6 months glass ceiling gets put in place. First of all, people are starting with poor mobility. Their movement lifestyle gets even worse. So there's only one direction where their existing mobility is going to go. Yet to learn to walk requires biomechanical advantage. And so you will also get something, as well as the neurogenesis and the neuroplasticity, you will also get what's referred to as spontaneous recovery. That's just your body's ability to recover from an injury by itself. A lot of this will be management of inflammation, for instance. And as the inflammation subsides, all of the compromises that inflammation was bringing, they will go, and some skills will return. And some of those skills will enable further skills, and people can get better that way. So I would actually suggest that overwhelmingly the improvement that takes place during those first 6 months is as a result of spontaneous recovery. It's more in spite of the rehab methods employed rather than because another thing with starting to immediately starting with walking is not the most basic movement skill. It's the only standards of movement that the World Health Organization agree on is that within the first 18 months of life, people should have established the ability to roll, crawl, there's some kneeling postures, squatting, and then walking. They are the only agreed quality metrics by the World Health Organization. But both by statement and by inference, walking depends on all of those patterns that come before it. A baby doesn't fail to walk immediately because it lacks the mental maturity to work out what walking is. It's because the necessary neurological and physical patterns of rolling, crawling, kneeling, and walking. I think hopefully the relevance of crawling should be reasonably self-evident, with the contralateral pattern of a hand and a leg moving at the opposite arm and leg moving at the same time. That's what happens when you walk. I mean, all of you can do it now as you're sitting down. If you try to crawl as you're sitting down, you'll see that is analogous to walking and or running. But it also starts to establish strength in the hips. And the lumbar curve also gets developed when you're in that position. Likewise, the cervical curve, because the head comes up to look where it's going. These are crucial fundamental building blocks to be able to walk. Now, if you've lost the ability to walk, the chances are you've lost all of those primitive patterns as well. And yet, if you just go straight to walking without learning these building blocks, well, you're going to get exactly the poor outcomes that are being experienced right across the industry now. The relevance of rolling might not be immediately apparent. When a baby rolls, I don't know how much of when you're rolling, you reach this way and you can see that. Well, actually, I'll take someone else coming in. I'll take it back another way to demonstrate it. When you walk, you go right arm forward, left leg forward. Now, you can do that yourselves now, and you'll see that your shoulders point in one way and your hips are pointing the other. Now, the shoulders and hips are obviously connected by the same spine. Now, if the top half is pointing one way and the bottom half, if the top is pointing one way and the bottom is pointing another, that means the entirety of your spine has to corkscrew. Now, you've got the lumbar spine, 5 vertebrae, 12 vertebrae in the thoracic. Just there, you've got 17 vertebrae. Now, if it corkscrews, they've all got to be in a unique position. And not only have they got to be in a unique position, they've got to maintain congruity with the joint above and the joint below. Now, neurologically, that is a big, big deal. If you think about it, you won't be able to control it cognitively. It has to be your movement brain, your reflexive movement brain that controls that. But think about how difficult that is. And then think about trying to learn that skill while you're standing up, whilst you've also got the challenge of trying to remain upright under gravity, but also you're very aware of the cost of failure. Whereas if you're up and you don't dissociate the spine correctly and you fall, well, that's serious, serious injury. And your neurology knows that. And so it'll brace up to protect you from that fall, trying to make you stable. But the moment you brace, you can't dissociate your spine. And then that's when you get that classic stroke walk of the same hand, same leg moving at the same time. And so when the baby rolls, the place to learn that skill is on the floor where you can't fall off. And so that's what the baby is learning when it rolls. It's lying down, its hips are in place. It turns its head first, sees something it's interested in, reaches for it, and then you get that dissociation of the spine. And that dissociation of the spine is what's necessary when you've got that contralateral pattern of left arm, right leg. The spine dissociates to facilitate that. And so if these building blocks aren't put in place and a subject or a patient tries to learn walking without them, well, you've got a very small base for your movement pyramid. And that means that the height of that pyramid is going to be very low. And that height represents the quality of movement that patient is going to be able to attain. And that is going to top out on that 6 months. And then the thing is, the real big problem there is, and it's possibly something to do with the limitations of state provision of healthcare, because it would need almost day-to-day movement rehab, not expensive stuff, not needing exoskeletons, but just knowing people who are familiar with what the patient should be doing. So maybe that's outside the scope of state healthcare. They just immediately want to get somebody to a point where they can self-sustain their own lives as soon as possible. And that this low movement pyramid sort of ties in with that. But as we said about neuroplasticity, if that's their base, they can't improve that movement skill that they've got much further, if at all. And if they try harder, well, that's just going to cause injury. You know, let's go back to the car analogy. If you've got mechanical failings there that start limiting the performance of the car, if you tried to get the car to work harder to perform higher, it might respond for a while, but then it'll get injured. It'll break. And that's the position the patient's left in. But he's been given skills that he can service his life with. And how open is he going to be to sort of throwing them all away and going back to learning rolling and crawling, which is that's exactly what he needs to do. It's those patterns have to be learned to put the books on the shelf in the right order. Now, what I was going to do next was I'll talk about my own story and how I can speak from all of this on experience, or from experience rather. But if anyone's got any questions at the moment, if anyone's still awake, I'll be more than happy to answer. You know, just throw up a hand. Don't feel obliged, but you know, Claire,
You're on mute, Claire. See if I can unmute you.
Yeah. I think Claire has to do it herself, doesn't she?
Yeah. Claire, you're on mute.
Yes?
There we go. Yeah, we can hear you now.
Okay, sorry, I thought I'd pressed the right button. How did you get it? Was this your background before you had the bleed, or?
Yeah, this is the next stage of the story.
Okay, yeah, I've preempted as always.
Yeah. Don't wish time away, Claire.
No, I'm just fascinated. I love it. It's my kind of thing that gets me all excited. So yeah. No, sorry, go for it. Let you tell the story.
Anyone else got any questions? Right. So 6 years ago in May. Oh, Carla's got a question. You'll have to unmute yourself, Carla.
Carla, I think. You're on mute, Carla.
There we go.
Hello.
Hi.
What about a cavernoma in the initial of
In the brainstem?
spinal? Really here in the initial place of the spinal. It will be
is it a cervical or brain?
Yeah.
Cervical.
Brain and
brainstem.
Brain,
yeah.
With that can if it is removed, I can be lay down for the rest of my life. So I have, it's a tricky place.
Yeah, it's a hell of a decision.
The doctors don't want to surgery because it's risky, but there's a problem that can be bigger in a few years or more.
Yeah,
and then it will be a very difficult decision.
Yeah.
Can you?
Well, what I can do is mine was a brainstem cavernoma, quite a significant one as well, and I had a catastrophic bleed from it. So my story will give you some insight into that. But all I can say is I can absolutely empathize with what a difficult decision that is. I was given the decision as to whether I wanted to go for surgery or not. And I just had the stroke and I was hospitalized with the stroke. And I was in a little bit of a similar position to where you are, although I was aware of the life-threatening implications that bleed had. It was that bleed that made me aware that I had the cavernoma, although I can now retrospectively identify possibly about 3 different occasions where I think I had a bleed and wrote it off as something else. So yeah, it's very difficult. I know there's some ongoing, seemingly successful research around, well, I think it's bleed prevention as opposed to elimination of the cavernoma. Maybe Joe, you could tell us something on that. I know the Angioma Alliance had recently announced something on that, and so that's part of the watch and wait, is hoping that medical science solves the problem in a less risky way.
Another effort that I have to do is not to be stressed, so that the cavernoma will not get bigger, so that it has really to be removed, and we don't want that.
I mean, something which I would underline as being possibly the most important thing anyone and everyone can do if they are going to go into surgery, especially elective, is to become familiar with and conversant with all of the things I was doing beforehand. Now, I used to do them just as part of my normal physical routine, which I'm decimating my story here, giving away all of the gold. However, all of the things I used to do, all of the things I needed for my recovery, I already used to do, so I was familiar with it. But the point I'm trying to make here is it would be so much immeasurably more beneficial for people if they were to, first of all, become familiar with the movement skills, and secondly, address the mobility issues, which are essential for being able to relearn to walk or address movement problems. It's so much more important to do it before you get the cerebral compromise of surgery, because that's where there's good luck and bad luck. I had the bad luck of having the cavernoma and the stroke, but I had the good luck to have everything that the story I'm going to tell you will come out with.
I had a bleed and the stroke in the cavernoma here.
Yeah.
I lost a lot of things in this temporal disc, and then I have another 2 here and the last here. So I got surgery. They took 1, 2, and 3, and they didn't remove this one because it's the tricky place.
So
thank you.
I can't give you direct advice other than I would say learning these movement principles and restoring the mobility, which for just general health, I couldn't recommend. I'd recommend it to every waking person on the planet. But for anyone potentially going into surgery, it couldn't be more important. Anyone else? No? Right, well, I'll move on to the story that I've just thrown a load of spoilers out onto. It was 6 years ago in this May that I had my stroke and surgery. It was a medullary brainstem stroke. As I just said, that was the first I learned about it was experiencing the stroke. I'd had other symptoms previously where mostly vomiting and just feeling awful. 1 or 2 times of a momentary loss of blood pressure, but then also just I don't know if I suspect there might be some people here who experience similar. I used to get a nagging suspicion that I had a brain problem. Now I'll go into. I have a medical background, although it's in trauma, And the only thing I could rationalize was that it was an aneurysm. I didn't know about cavernomas. And I just couldn't bring myself to take myself to the GP and expect him to take me seriously if I sort of said, look, I've got a nagging feeling, I've got an aneurysm. He'd say, yeah, all right, Steve, there's the door, you know. But I'd had this for, I was at a football match, and I'd had a few beers with it as well, which will affect both blood pressure and control. And then it was Liverpool versus Bayer Leverkusen in the European Cup, and it was some quite enthusiastic shouting, and one which causes vasotension, and I really put it into the shout, and then I got a real warning sign. Went, whoa, stop doing that, otherwise something's going to pop. And I obviously took heed of that. I thought, wow, it was a bit weird. But then ever since then, I used to have this nagging feeling about if I would brace inappropriately or spike pressure, that I had something that was going to, something vascular that was going to go pop in my head, which I could only rationalize as being an aneurysm, as I said. And I couldn't rationalize it any further. Anyway, that would have been round about 2000, probably 99 actually, when that happened. And then I had another similar occasion again. This time it was at a boxing match, similar situation of booze and enthusiasm. And then that was when I actually lost my feet and just straight down, collapsed into my chair, which, again, couldn't understand. Just put it down to the booze, to be honest. And then just had that nagging feeling. So it was 2017 when I had my stroke. And ironically enough, for about the month before that nagging feeling had really, really got stronger. And I actually thought, well, I am going to go to the doctors and just have a conversation with them, because, well, that nagging feeling had got stronger. But then, time beat me to it. But I had a catastrophic stroke, lost the ability to walk, double vision, problems swallowing, spasms of my airway. I mean, I've twice gone unconscious through coughing. I had left-sided weakness. A whole host of other symptoms, which I'm sure many will be familiar with. I was immediately hospitalized, and spent 2 weeks in hospital, ahead of then 10.5 hours of brain surgery. There's a general rule of thumb that the duration of the surgery will correlate to the extent of the impact of the surgery. I'm sure if someone just went in and rummaged around with a blunt spoon for a couple of hours, then it wouldn't be too beneficial. But 10 hours of surgery is a significant period, and I was absolutely smashed by the surgery. All of that is the bad luck side of the story. But what the good luck side is that the previous almost 20 years of my life had been such perfect preparation for that it was almost like predetermination. 20 years previously, I joined the Reserve Armed Forces and tried out for the parachute regiment. I was successful with that. I did 2 years in the paras and then did SAS selection. I was successful with that, and then went on to spend 12 years in the regiment. That was where I got all of my trauma skills, but also in the last 6 years of my service, which was 3 years either side of a tour of Afghanistan, I was on the regimental training team. Now the role of the regimental training team is to prepare candidates for what's called selection, which is the sequence of tests for people to enter into the regiment. Now, as you can imagine, and by repute as well, it's quite a formidable test. So much so, each selection course would last about 6 months, and for 5 of the 6 selection cycles prior to my tour of Afghanistan, there was only 1 successful recruit. Now, it's supposed to be hard, but that is unsustainably hard for the future of the regiment. But then also standards couldn't be dropped. So, what to do there? Well, I knew when I come back from Afghanistan, I was going to be a senior figure on the training team. So I wanted to almost like take it on as a research project to see what was going on, because the reason why people would fail who had what we would determine as the necessary mental and physical attributes that we'd associate with success, the reason they would fail would be injury. But it wouldn't be sort of falling over and breaking a leg type injury. It would be what you'd equate to sort of chronic sports injuries. So iliotibial band syndrome, lower back problems, knee problems, ankle problems. And I wasn't having it that people just aren't as tough as they used to be, because these blokes were the fittest guys from each of their regiments. And I just thought we might be part of the problem. So when I come back, I recruited an osteopath friend of mine from Liverpool. Just before I deployed, I had a shoulder injury, and a friend of a friend referred me to this guy, Paddy Phillips. We hit it off immediately. Although he was as an osteopath, he was previously a firefighter and also an international martial artist. So he had a real good frame of reference for a high level of fitness, as well as having all of his medical and therapeutic skills. Whereas I was living the high level fitness lifestyle, but also had through all of my medical training, a good handle on anatomy and physiology. And then because of my roles in getting my own fitness up and that of others in sports science. So it was a real good meeting of minds. So when I come back, I got Paddy on the training team with me. And the first thing we identified, as I touched on earlier, is that it doesn't matter how fit you are. If you live the Western lifestyle, you will start to incur the sort of mobility compromises that come with that. And although all of these guys had super fit heart and lungs, well, they had these mobility compromises of the Western lifestyle. As I touched on earlier, if you try to raise or maintain high performance just through effort, if you've got these range of movement flaws, well, that just leads to injury. So it was reasonably conclusive, reasonably early, that our premise was consistent with what was presenting. So we were able to address this direct, and we corrected. And it's a very objective science, orthopedically restoring range of movement. Now we saw an uplift in both the pass rate and the recruit performance, but it wasn't what we'd anticipated or hoped for. But what we thought, and will later prove to be correct, is that just because these guys could move correctly doesn't mean that they do move correctly. Remember what we were saying about the bookshelf, and you put the books on in a different order, and the ones that use the most become the dominant ones. Well, these guys had built up and maintained their fitness with the poor range of movement. So although they could move correctly now, they also could move incorrectly, and that's what they were doing. So we decided that we were going to rebuild all of their movement patterns and to rebuild it from scratch. So we took them back to rolling, crawling, kneeling patterns, squatting. And only once we had competency in all of those did we start with the sort of movement training or performance training, which we had done previously. Now, the results we got were, remarkable to say the least. Now, there was a number of training locations. The same 0 to 1% pass rate persisted at all of the others, but at ours, the pass rate went over 50%. On the final intake, we started off with the least number of recruits out of any of 6 locations. But at the end of the course, we had more passes than every other location put together. And this is absolutely no word of a lie. I used to wonder, given the success we'd had, that why don't they use these methods with brain injury patients? And I obviously then got the chance to quite literally walk me talk. So after my stroke, I was hospitalized for 2 weeks. I couldn't walk. So I got my wife to bring in an exercise mat into the hospital, and I started rehabbing myself on the hospital floor, reinstating rolling, crawling, focusing on me kneeling and squatting patterns. And by the end of the 2 weeks of my hospitalization, I was able to do something which could reasonably be thought of as walking. And something which is quite interesting and quite telling is the day before my surgery, I had an assessment by a physio and a doctor, both of them considerably younger than me. They did their assessment, but a deep squat, i.e. a squat all of the way down, wasn't part of it. And yeah, I'd been working on that. So I wanted to converse with them about it. Now, out of the 3 of us in the room, only one of us could do a deep squat. Now, I imagine you all know which one that was. Now both this physio and this doctor would have considered themselves to be physically fit, especially the physio. And they were both considerably, 10, probably near 20 years younger than me. But they couldn't do a deep squat. Now, that's not genetic. That's living in the Western world and losing your mobility. So whilst both of these physicians could walk, clearly, neither of them had the mobility to learn to walk if they were put in a situation where they had to. And this is sort of ties it all back up to what I've been talking about today. And so after my surgery, if I was bad after the stroke, the surgery just destroyed me. I say it was 10.5 hours. Previously, I had left-sided weakness. Now it was bilateral. Whereas before, I couldn't walk. I couldn't even crawl after the surgery. One thing was the strangest thing. I managed to get myself up onto all fours, but the idea of moving an arm or a leg, it just wasn't in the program. I had no idea how I could do that without the certainty of just piling straight in. But what was mad was whenever I self-supported, I could actually feel gravity. I could feel it sucking me to the floor. The feeling if you ever go in a kid's play park or a fun house or something like that, and you get a spinning wheel or a roundabout, and you feel centrifugal force throwing you out. I could feel gravity like that. I was so devoid of any reflexive stability. I could feel gravity sucking me to the floor. It's the weirdest thing. But then I had 3 days in intensive care. And then once I was out of that, I then wanted to start my rolling, get on the floor and start rolling. But then I'm stuck in a high-sided hospital bed, where the intent of that is to actually stop me falling out or getting out. I couldn't walk. I could hang on to stuff and make my way into I was in a private room, so, you know, I thought it'd be more beneficial rather than calling for a nurse to take me to the toilet. I could just hang on to stuff and drag my way in there. It would be slightly more discreet and have a little bit more self-respect than being taken to the toilet by the night nurse as well. Like, so I thought, hang on, if I stay in here, my mobility is just going to start getting worse and worse, and mobility is what I need to restore my movement. And something I'll go on to in a minute, there is a very, very beneficial aspect of living your movement rehab, of by using, in exactly the same way as a baby would, using crawling for your mobility and experiencing the world from on the floor. So I had that conversation with the physios, and they were, no, it's, you know, we're going straight to walking, and you know, that classic model. And I said to him, and I was very respectful, but said, can you tell me, or are you telling me, that walking is the most basic of movement patterns? It doesn't depend on anything. Or does walking depend on these primitive movement patterns? Yeah, it does depend on them. Righto. Well, we are going to have to agree to disagree. And I signed myself out of hospital still in a wheelchair, and I looked after my my own recovery. Now my prognosis was a 2 to 3 year recovery with permanent deficits and a potential need for a walking adjunct, such as a Zimmer or a cane. Well, I went home and I resolved that I wouldn't try to walk until I had competency in all of the primitive movement patterns, such as rolling, crawling, squatting, and kneeling. Because if I tried to walk, it would just get in the way, and then I would also be reluctant to try to give up whatever compromised ambulation pattern I've got to go back down and crawl, because it's inconvenient. But then also, the act of crawling feeds into you learning the skills of walking in an incremental fashion. It's difficult for me to show you, you know, without having a camera of me down on the ground. But when you're crawling, if I see something I'm interested in, I'll crawl over to it, but then I'll come up onto my knees to free up my hands so I can do something useful with them. But as soon as I come up on my knees, from the knees up, I'm standing up. I'm practicing an upright posture. I've got an upright pelvis. I've got 2 points as my base of support, which is both my knees on the ground. So that's acting the same as standing, but I'm at a reduced height. So I've got a reduced center of gravity. So there's a reduced challenge. And whenever you want to try to learn any skill, you want a reduced challenge environment. And then, this is also one of the big take homes, is that if I come up onto my knees, if I fail in that position, I just put my hands down and then try again. Whereas if I'm standing and trying to learn standing and walking from up there, if I fail, well, that's significant injury. And so it is so, but this is the way we're designed to learn movement and to learn the movement skills that feed into walking. This is the way all of us learned how to walk, and none of us needed a neurophysio to do that. Now that's not instinct or intuition. That's nonsense. That's like a medical word for magic. That's a medical word for, I don't know the reasons why this happens. And that is the reasons why it happens. It's driven by need and experiencing it in that way. And the baby solves its problems with the most efficient and productive option, and it forgets about the bad options. And then it's only got the good options as its base. And so the options that it makes off the back of that base are only going to be good and authentic options. And then so it continues until, well, I don't know, the baby gets about the age of 5 and then goes to school and then starts spending a large part of its day sat down. And, you know, I'm not sure if mine was probably the last generation that used to spend, you know, the majority of its playtime or free time out in the road playing football or running around the parks instead of just sort of sat like a phonadillo, you know. And so that's a problem where all of this is going. Now, I sort of suspect that looking at me now, it's probably very easy for me to talk up how bad I was.
Is your story rare, or do you know others that have had similar experiences to you?
As far as I'm aware, other than the people who have gone on to help, mine's a unique story. Although with respect to the others who have gone on to help, I think I mentioned earlier, I presented at the last 2 World Congress for Neuro Rehabilitation. The last one was in Vienna in December. And so for the abstract, I was presenting there because I was just routinely ignored at the first one, although that was during COVID. And so it was all online and, you know, far easier to be ignored then. So I wanted to have some objective results to back up my claims rather than it just being just me. And so I started something called the Movement Project, which was a research project to underpin my rehab philosophies. And what I did, I took, I think it was 10 brainstem cavernoma patients who'd suffered stroke and or surgery. I think actually all of them had suffered both stroke and surgery. And all of them were in the chronic phase of recovery, where the standard, the industry standard says that no significant improvement is possible. And so I then used all of these principles on those guys, and the results were incredible. Now, it would have been a lot more productive if they'd used these strategies immediately post-injury. But the fact that they were able to get such good results in the chronic phase, it just underlines that what they say about correlation is not causation. That 6-month recovery period, that's the correlation. That, yes, the statistics have shown that's proves to be the case with people, but it's not because it has to be. It's more as a result of their previous movement lifestyle and what I would call a suboptimal rehab approach. Now the results we had from it were that good. We didn't have the heart to stop it, and the movement project continues to this day. It's actually going to hopefully evolve as well, which I'll talk on that at the end. And if I forget, Joe, give me a prod, and I'll talk through that, because a lot of people might be interested in it. And so I'll take you through a number of videos now, which sort of show my recovery, because I was aware that I was breaking new ground on it. I sort of blogged my recovery. This will be one of the earlier ones, and I'll just sort of chat in between each one.
My name's Steve, and I had a brain hemorrhage just on 3 weeks ago, or 3 weeks ago yesterday. I had a cavernoma, which is a venous, vascular malformation. It was on the brainstem, bled. As a result of that,
oh, we've lost the sound there. You know, that video sort of underlined the impact it had had. I would like to hope that other than the haircut, I mean, I present a little bit different than I did then. Here, I'll talk about, well, I'll try and demonstrate my first attempt at walking.
Okay, as the just as a bit of a marker that we're trying to walk. As it happens, it'll be the last time I try to walk until I mastered all of the, the development sequences. Looking for the
calls from 08456 0211111. Calls from 084.
Right, so you can see how the compromised walking there, which one of the most obvious symptoms of that is what I call the stroke walk of instead of it being left hand and right hand moving at the same time, it's left hand, left foot, and you're getting that Robbie the Robot type walk. And the next one is a video of me 8 weeks on. As I say, my prognosis was a 2 to 3 year recovery, but this was 8 weeks in, which you can see I'd already surpassed all of the prognosis targets I'd been given. So as you can see there, I'd introduced climbing into my movement recovery. And that's a really important, it brings with it a really important concept, and that's that of a reason to move. Now, I mentioned something earlier which links directly to that, and that is the benefit that came out of crawling, of where if there was something I was interested in, I would crawl over to it and then come up onto the knees to free that up. Now that's something that a reason to move has introduced into my movement, because one of the key things is movement isn't cognitively controlled. You might give yourself a cognitive intent or a cognitive target, but when you move authentically, you don't start saying, right, I'll contract my bicep and then I'll extend or I'll rotate this. Whether you know the medical name for it or not, you don't have a conscious control on a parts level. You give your movement brain an intention, and potentially you might maintain focus, but you don't cognitively start controlling the working parts. And that is also one of the major flaws of standard rehab practice, where they start isolating individual muscles. And I mentioned earlier that if they find a tight muscle, they'll stretch it. If they find what they see as a weak muscle, they'll isolate it and strengthen it. Well, that might sound intuitive, but is that muscle tight because it's short, or is it firing inappropriately? If it fires inappropriately, it'll tighten up. But also, is it tightening up to try to provide stability? Because the the primary stabilizer in that situation isn't working, so that muscle stiffens up. And then if you just stretch that, well, you've then removed whatever stability that it's got. But so if you cognitively start trying to take it down to a parts level, it is not going to work. It'll work for a bodybuilder and he'll get a big muscle, but also big muscles don't provide performance. I mean, for instance, who's going to kick a football further? Mo Salah or the largest bodybuilder in the world? There's no contest to who kicks the ball further. But the largest bodybuilder in the world, he's covered in muscles. His leg is probably about the size of Mo Salah. So it doesn't work that big muscles create performance. You know, it's the symphony of parts working together. And so when you have a reason to move, you get out of your own way. You don't cognitively control the movement. The reason to move gives it the intent, and you say, get out of your own way, and your movement brain takes it. And so when you climb, that's very definitely one of those situations. So climbing is crawling pattern, first of all, which is great. But then also the fear and heights and how they come into it, that definitely pushes you out of your own way. And the activity tells you what you need to do. That's really, really important. Now, there was something that was mentioned earlier, I think, about balance. Now, and something I mentioned about movement being hardware and software, and balance, this feeds into this mobility thing again. Balance just gets talked about as if it's a singular skill. The structural component of balance is enormous. You think about it, if I have to try to balance this, I can do so on my hand, but I can do so because it's a solid vertical column. However, if I try to balance it like that, there we go, calamity. And so if somebody's mobility is compromised, that their posture is no longer upright and things can't get in the right position, then they're going to be similarly challenged. Now, if your posture is challenged, then the neurology has to overperform to make up for that challenge. But we already know the neurology is injured. So it just doesn't make sense to just plow straight ahead onto walking and just repeated attempts at walking to try to re-educate people. Now, there is just one more video in there, but I'll leave that in abeyance for now, because it's essentially the presentation I did at the World Congress, which is a good summary of the movement project. Now, what we're doing with the movement project is I want to take it a step further with the being able to demonstrate the objective results, because what I did previously was we went, right, we're going to do the rolling, crawling, do the neural development sequence, which is the name for that, as our rehab, and then record the progress. Well, the progress was huge, but then I also now want to take it to the point where we can get the objective mobility metrics beforehand and say, right, out of all of these people who are looking to improve post-injury, here's all of their mobility metrics, here's where their shortfalls are, and they're already in the chronic phase, and so they should expect no recovery. And then want to record the metrics of improving that mobility and applying those rehab techniques and following the movement project through like that. Now, what I've done, particularly, well, in a number of the forums in CAV UK as well, is I've posted occasionally about individuals' progress within the movement project. What I would like to do, and what we do in the movement project, we have 2 group rehab sessions online a week. The majority of people in the movement project are in the States. Some of them are in a couple in the UK, one of them in Europe, the rest of them in the US and Canada. So what we would like to do is we would continue with these recorded sessions and then make each recorded session available in the CAV UK forum for people both just to follow and or ask questions on as well, to try to get the, as far as benefits concerned, do the most for the most. So yeah, they're the plans for the movement project. I'm actually talking to a guy called Greg Cook tomorrow from the US, who is, in my humble opinion, the world's leading authority on movement and movement rehab. And I'm hopefully going to get his buy-in to the project as well, but we will see.
Thanks, Steve. Has anybody got anything they'd like to ask? I'm asking about dizziness and things as well, because I know we've talked lots about mobility in terms of, you know, not being able to walk, that type of thing, but in terms of the other elements to cavernoma, like the dizziness and, you know, the paralysis on one side, does this apply to that as well? Can we use these methods for that?
Well, the dizziness, there'll be sort of 2 aspects to dizziness. One will just be a compromise from some of the working components, some of the physiological components of it, and also an aspect or a sense of dizziness will present when there's an absence of control, either just as the awareness of loss of control or because of loss of control. So that would be one aspect. Something else, which is an anecdotal intervention, and so I'll just talk about it with respect to what's happened to me and numerous others. But pretty much every single brain injury patient who I have worked with has suffered from this symptom, and the same as myself, and it results from a blocked eustachian tube, which is a tube in your ear. I think probably everyone knows how central to balance the components of the inner ear are. Now, this tube should allow flow of sinus fluid, I think essentially to then drip down, I think it's down the throat. But either way, it should be passing through this tube. Now, this tube can get blocked, and I have a strong suspicion that there's a correlation between sinus problems and brain injury, probably as a result of inflammation, but all of that is just me guessing. This is pure anecdotal, because I know this presents, and with me, it presented to the point I actually thought I was having another stroke. I was sat in a chair, but I had to hang on to the chair not to fall off, because that's spiraling dizziness. And I suffered with it for a number of days. That same osteopath I mentioned earlier, Paddy Phillips, who's by then a good friend of mine, I went to see him, and there's a procedure where you can take the ear, lift and twist it, and then give it a very sharp tug, and you hit a click, and it clears the eustachian tube. And it was like a magic wand. I had previously a cloudy head and a real sense of dizziness, and then bing, gone. Now, I have been able to find a YouTube link which demonstrates this procedure. It's a pretty annoying guy who does it, but the procedure he demonstrates is valid, and that is one because of how it is presented with everyone I've come in contact with who's had brain injury, and it presented really acutely with myself. It's something I put a lot of store by, but as I said, I do not know the pathophysiology behind it, but I think it is something very relevant for me to be talking about.
Yeah. And just on that as well, because I know a couple of people have mentioned it as well, is the neurofatigue that comes from, stroke, from bleeds, from that rehabilitation. Did you struggle with that during your journey, or was that?
Hugely, and it presents really frequently with the people we work with, especially on the movement project, and it's often a very good sign. It's usually a sign that neuroplasticity is taking place, or rather it can be a sign of two things. It can be a sign of overdoing it and fatigue, stroke exhaustion, if you will, physical fatigue inducing neurofatigue, or it can be a sign that neuroplasticity is taking place. It is anecdotal correlation, but it is absolutely consistent that whenever people demonstrate a big leap, as in where something clicks into place and they get it, and they gain this movement quality, they go into neurofatigue. What I've found is the more compromised somebody is, number one, the bigger the leap they can make, but then also the longer the period of neurofatigue. And you can get it, as I know for myself, where you are just wiped. Someone's taken the dilithium crystals out and no energy at all. And it's different than not having the energy to go out for a run. It's a neurological neurofatigue, isn't it?
Yeah, I know a lot of members describe it as a pure exhaust, like your body, you're just exhausted. How did you? Because you mentioned there's like the three types of. How are you aware of which one is a physical impact and which one is, can you tell the difference between it?
Can't. The only way I would tell the difference is because of past behavior. Have you been overdoing it? If you've been overdoing it, well, there's every chance. Now, you could have been overdoing it trying to acquire movement skills. And so which one is it? But what I would say with that, so that shouldn't interfere, because it's not effort, it's not force, it's not it's quantity of quality. Now, unfortunately, there's a belief to a level that it's a universal accepted truth of no pain, no gain, go hard or go home, and that the more effort you pour into something, and often the more discomfort you feel while in a physical endeavor, then the greater the reward. That is utter nonsense. Now, I spent 12 years at the performance level of Special Forces, so no one's got, I've done multiple ultramarathons, including the 150-mile race across the Sahara Desert, carrying all my kit. I know about physical hardship and discomfort and physical training, and progress does not come from just pouring physical hardship on yourself. It has to be quality. Now, your body is resilient and it will try to build itself back up. But why incur an overhead like that if you don't have to? Not least because there's a load of baggage that comes with that overhead. It is all about quality. And those patterns that neuroplasticity lays down, you can think about them as paths across a grass field, or even through a cornfield, let's say, where first of all there's nothing there. You walk across it once, you can see the path that you've gone, and then it's a bit easier to follow that path, and you can move a little bit quicker. Well, that's exactly the same. Each time you put the books on the shelf and you make a circuit, and then each time that circuit is executed, you put down what's called a layer of myelin. This myelination process makes the pattern easier to access and more quicker to execute. And so each time you walk on that path across the cornfield, it gets easier and easier to follow, easier to go quicker on. And that's how you reinstate a skill. And so if you keep doing it and keep getting fatigued, then you'll stray from the path and you'll start bringing in loss of quality, and you'll also start risking introduction of injury. And as soon as you're injured, that will close off one of the paths.
Great, thanks. Has anybody got any questions?
Barbara's just...
Barbara's just... Hi, Barbara.
My son-in-law has brainstem cavernoma removed very successfully, absolutely super, probably about 2 years ago, but he still has a lot of sympathetic problems. So after an hour or so, he can't pick things up very easily, but also when he touches things, he has, electric shocks, same with his foot and all the rest of it. Have you noticed any of your experience with others who've had these sorts of problems? Has it ameliorated with doing the step-by-step progression?
It ameliorates with quality. There's a definite correlation between quality and control, and then the more fatigued you get and the dip in quality, you start to get those symptoms.
Yeah. But because I'm actually an ex-neurophysio from generations ago, but I did do a thing called the Bobath course for neurology. And they were saying exactly the things we were taught, exactly the things you're talking about. So it's quite a relief to see that back into vogue. But I just wondered how much it had affected people with sympathetic problems. But okay.
So that
roll around on the floor and crawl about. It's a bit late now. Anyway, thank you very much.
No, a pleasure, Barbara, and more than happy to chat if you got the past experience on it. I'm aware of the Bobath method that doesn't take it quite as far back as the neurodevelopment sequence, but it is.
Primarily, they were pediatric, but I actually did their one for adults. So many years ago.
I think somebody posted on there when I was saying about the laying down of the myelination of the patterns, and I think they said repeat, which there's something to it, but you want repetition without repetition. Now, people's going to say, what the hell does that mean? Now, you've got two different types of practice, and that is block practice and what they call random practice. So you could, for instance, let's see somebody taking basketball's a good example, even though I loathe the game. People doing free throws. So you've got your free throw mark, and if you just practice from that exact same spot, throwing that ball in, you'll improve, and you will improve overall, but you'll improve most within that one session. And if you've got somebody else who is taking throws from all sorts of random positions, at the end of the session, if they both test themselves on free throws, the person who is doing the block practice will perform better. However, the next time they turn up, or the next time after that, the guy who does the random practice is all of a sudden better than the person who does the block practice. When you do the block practice, yes, you'll get better within that session, within that sort of almost like bout of memory, but you're not teaching yourself anywhere near as much about the activity. Like for instance, that's what's an example. Joe, what is 21 times 3?
63.
Yeah. Now, what is 21 times 3?
63.
Yeah. And what's 21 times 3?
63.
Yeah. Now see how
Good job I got that right, isn't it?
Yeah. See how Joe improved though. In that first question, it was thinking, and then went 63. Then there was a little pause, thinking, is he stupid or am I stupid? That was the same question, 63. And then the other one was lightning, 63. But what has Joe learned about multiplication? If I now say 4 times 17, whoa, that's a bit different. Now that's block practice. You don't necessarily learn about the skills. You just get that one utilization of it within there. You get that nailed down. But utility of real world skills is so much bigger than that. That's why just with a weight and just going there like that's why that gets a big muscle here, but not a muscle that can do anything. It has no application. And so, as Joe brilliantly demonstrated there, that's the difference between block practice and random practice. So yeah, 3 times 21, that's really useful. And if you start mixing that in with all sorts of different presentations of multiplication, Joe would learn multiplication. I'm sure she's already very adept, you know, rather than just be an expert in 21 times 3.
That's a good analogy for, I think, all aspects of life, isn't it?
Absolutely.
Not just this. Yeah. Brilliant.
Yeah.
I'm just mindful
Steve
of time.
Cairns, life coach.
Like it. I'm just mindful of time. Has anyone else got any questions they'd like to ask Steve before we finish?
I wonder if you've heard of the Feldenkrais method.
Do you know, a number of people have said that to me, and you know, I'm aware of it as a method. And every time I hear about it, people talk well of it, but I don't know anything about it. I have to be completely honest.
It's very interesting. I think you might be interested.
Yeah.
He had an
every
injury.
Time someone asks me, they always say that. I go, I must have a look at Feldenkrais.
Check it out. And where are you? Do you actually work in hospitals or anything, or are you just through the movement project?
No, it's sort of private practice, so to speak.
Right.
Yeah.
Yeah.
I've given a couple of presentations in the hospitals in the area.
Right. And will you be running up Snowdon when the Cork do their Snowdon thing?
No, I haven't signed up for that one. Like, unfortunately, my missus has me quite tied down because the amount of time I spend away on various things. Like, so, you know. Are you going up, Claire? Are you?
I don't know. I haven't decided yet.
Hopefully, I've signed up to that. Well, obviously, we're doing it. It'd be nice to see you, Claire, if you do.
What's the
in
date
Wales,
for it?
so it's not too far.
Yeah.
What's the date? Is it the 2nd of June?
It's Saturday the 2nd. Let me just double check that. Yes. Oh no, Saturday the 3rd. Sorry. Saturday the 3rd.
And it's a slight aside, but I suppose it's all part of what you're saying, Steve, about fitness and keeping up the fitness, which I think, and I mean, one of the things I did afterwards, like I say, I had a background in Feldenkrais movement, was swimming, which was also because it was something I had done before. And in the world of movement worked, I mean, obviously neuroplasticity, but they also call it mapping, what you were talking about, the cornfield, you're remapping each time. So there's various people who have done lots of stuff around that. Anyway, fascinating. Thank you. Really fascinating.
Pleasure.
Yeah, brilliant. And we'll be sharing a lot more of what Steve's doing on the website and social media and things like that. So, yeah.
And do we get to the last video? Oh, and who was what was the Dylan track? It's not a track I know.
It was off Blood on the Tracks. Buckets.
Lovely. Anyway, no, thank you. That was fascinating.
Yeah, brilliant.
My pleasure, Claire. Glad you enjoyed it.
Has anyone else got any questions to ask Steve before we finish up? No? Yeah.
Lovely.
Thank you, Steve.
Thank you so much.